Three, two, one. Please start, ma'am. We are live.
Good evening, everyone present. I welcome you all for today's webinar on Meet the Oncology Experts Treatments Update 2025. With the immense pleasure, I would like to invite our first speaker, Dr. Abhishek Bansal. He is a consultant medical and hemato-oncologist from SSB Multispecialty Hospital, Faridabad. The stage is all yours, sir.
Good evening, and thank you for the kind introduction to the organizing team. And without wasting much time, I will start with my presentation. So, yeah, can I have my slide stack ready? So, today I'm going to speak on the topic Advanced EGFR mutated non-small cell lung cancer, a evidence-based review of targeted therapies. Next slide, please. So coming to the lung cancer epidemiology, globally in 2020, lung cancer is second most common cancer diagnosed in males and third in females. And it is the number one cause of cancer-related mortality in males and number two in females. And coming to the Indian scenario, it's the fourth leading cause of cancer death in India and fourth in overall incidence. So, so no non-small cell cancer is the most common type of the lung cancer. So, next slide, please. So you can see as the relative survival rates vary by the stage at diagnosis, and 5-year overall survival decrease with the increasing stage in NSCLC. So you can see the stage-wise diagnosed cases. The maximum stage uh, of lung cancer are found in late stages, which is 3 and 4, and more in 4, that is distant metastatic stage. So as you can see, this by this graph, the 5-year overall survival decreases as the stage increases. So stage 4B has 0% survival rate and stage 1A has 92% survival rate, and in between the various facts and figures are shown to you. So next slide, please. So the coming to the biomarkers, more than 50% of stage 4 NSCLC have biomarkers. There are predictive biomarkers and these are prognostic biomarkers. So both these predictive biomarkers means they are indicated of therapeutic efficacies because between the biomarker and the therapy on patient outcome there is an interaction. And prognostic biomarkers are independent of the patient survival, indicator of the patient survival because of independent of treatment received because the biomarker is an indicator of the innate tumor aggressiveness. Testing for several genetic mutations and for PD-L1 status is recommended for patients with advanced NSCLC to determine whether they can receive treatment with targeted agents. So, coming to the testing methodology, this is all we know is the EGFR we test by PCR-based technique, the ALK by the previously we used to do by fish, but nowadays IHC has become the gold standard, and ROS we do the fish testing and PDL1 by the IHC. Next slide, please. Now coming to the most common driver mutations in lung cancer, among the EGFR mutated lung cancer, the 19 is the most common, followed by 21, and the other less common being exon 18 and 20. Next slide, please. The prevalence of EGFR mutations across disease stages. The Asians have a more EGFR mutations as compared to the Caucasians, and the prevalence estimates for each stage. If EGFR TKI were available in the resectable setting, our similar percents of patients may be able to benefit compared to the advanced setting. So, next slide, please. So you can see the responses to the EGFR TKI. That next slide, please. So osimertinib is a third generation irreversible CNS active EGFR mutated TKI selective for both EGFR mutant and EGFR T790 mutation. T790M resistant mutations. So it is selective for EGFR TK sensitizing mutations, L858R and exon 19 deletion and T790 mutation resistant mutation. And it leads to inhibition of EGFR mutation, exon 19 deletion, inhibition of T790M, and lower activity and on wild type EGFR. Uh, Next slide, please. So coming to the Flora, this was the trial which set the landmark for osimertinib in the current guidelines. And it was a phase 3 trial to study the osimertinib versus standard of care EGFR TKI as the first line treatment in patients with locally advanced or metastatic EGFR mutated non-small cell lung cancer. Next slide, please. So coming to the design, patients with locally advanced or metastatic non-small cell lung cancer, it was a phase 3 double-blind build study conducted across 152 sites in 29 countries, and key inclusion criteria was 18 years, WHO performance status from 0 to 1, exon 19 deletion, L858R, no prior systemic anti-cancer EGFR TKI therapy, stable CNS metastasis were allowed. And osimertinib was given daily versus compared to the standard of care, which was gefitinib or erlotinib, and racist 1.1 criteria was done as the for response assessment, and crossover was allowed patients with confirmed progressive disease or by independent central review on standard of care and T790 mutation positive may begin post progression open label osim, uh, osimertinib. Next slide, please. Primary endpoint was PFS and secondary endpoint was OS. The baseline characteristics were as follows, and you can see they were balanced across the treatment arms. Coming to the age and the sex, the race, smoking status, CNS mets at study entry, WH performance status, overall disease stage, and the histology and the EGFR mutation. Next slide, please. So you can see this Kaplan-Meier curve in which the osimertinib curve has clearly separated it versus the standard of care, and the hazard ratio is 0.46, and the median PFS is 18.9 months versus 10.2 months in the standard of care, clearly meaning that osimertinib is the clear winner compared to the standard of care, with the graph separating, and it reduced the risk of progression by 54% compared to the standard EGFR TKI. Next slide, please. Now coming to the PFS across subgroups, a consistent benefit of osimertinib for over standard EGFR TKIs with respect to PFS was shown across all predefined subgroups, and the you can see the forest plot which is shifted to the left favoring the osimertinib in all the subgroups as we discussed, in which it was stratified the trial, the sex, the age, the race, the smoking history, and the CNS mets, the WHO performance status, EGFR exon status, or the CNS mets centrally confirmed EGFR mutation. So the Kaplan-Meier was shifted to the left, suggesting the this basically the winner, that osimertinib is the clear winner. Next slide, please. So you can see the objective response rates, the depth of response, or the duration of response. The median duration of response in osimertinib was 17.2 months versus the standard of care, which was 8.5 months. And duration of response was twice as long in patient treated with osimertinib compared to the standard EGFR TKIs. And next slide, please. The Flora OS final analysis hazard ratio was 0.799. Osimertinib OS showed the 38.6 months of OS versus the standard of care, which was only 31.8 months. And final analysis of OS demonstrated a clinically meaningful and statistically significant improvement with osimertinib versus EGFR TKI. Next slide, please. Flora adverse event summary: median exposure of osimertinib was 20.7 months and TKI comparator was 11.5 months. And you can see the diarrhea, the rashes, uh, and the nail effects. These are all the side effects which are as expected in the from the EGFR TKIs. Next slide, please. So coming to the summary, Flora study, osimertinib resulted in highly statistically significant, clinically meaningful improvement in PFS over the standard of care, which was the primary endpoint, and the hazard ratio was 0.46, and it was 54% reduction in risk of progression or death related to standard of care with early separation of Kaplan-Meier curves, consistent benefit in all predefined subgroups, including patients with and without CNS mets at study entry. And it was doubling of the duration of response with osimertinib, median 17.2 months versus 8.5 months. A significantly clinically improvement in CNS PFS over standard of care. Hazard ratio was 0.48, and fewer CNS progression events and fewer new CNS lesions. Final analysis of OS results showed promising survival and towards osimertinib versus the standard of care, and the hazard ratio was 0.799. Preservation of PFS benefit from next disease progression in subsequent lines of treatment. Comparable safety profile of osimertinib to standard of care. Overall lower rate of grade 3 events and a lower discontinuation uh, rate. Osimertinib is the new standard of care for first-line therapy in patients with EGFR mutated advanced non-small cell lung cancer. Next slide, please. CNS efficacy for osimertinib. Next slide, please. Coming to the CNS activity, PFS in patients with and without CNS mets at baseline. With CNS mets, uh, hazard ratio was 0.47, and without CNS mets, hazard ratio was 0.46, and median PFS was 15.2 in CNS mets versus the standard of care, which was 9.6, and without CNS mets, it was 19.1 versus the standard of care, which was 10.9 months. So osimertinib benefit was consistent in patients with and without CNS mets, and fewer CNS progression events were observed with osimertinib than the standard of EGFR TKIs. Next slide, please. CNS PFS. You can see in CNS analysis state, osimertinib had a clear separation of curve versus the standard of care, and the median CNFS PFS was not reached versus the standard of care, which was 13.9, and the hazard ratio was 0.48. Next slide, please. Osimertinib versus dacomitinib. Next slide, please. This is coming to the comparison of PFS of osimertinib and dacomitinib. Efficacy PFS by this data, and you can see the Archer 1050 in this median PFS was 14.7 versus dacomitinib, which is 9.2, hazard ratio for 0.5 months, suggesting the efficacy of dacomitinib over dacomitinib. And in the Flora trial, you can see that the immediate separation of curves of the osimertinib arm 18.9 months versus the comparison, which was 10.2, hazard ratio was 0.46. So it was immediate separation in Flora, but in Archer 1050, at least after 6 months, the curve separated, suggesting a greater benefit efficacy of the osimertinib versus the standard of care. Next slide, please. So OS was not significant since the formal comparison of overall response rate was not statistically significant based on the study's hierarchical testing rules. So you can see the PS hazard ratio was 0.748, and OS was 41 months, was 33.6 months, but it was not significant. Next slide, please. While the first time on EGFR TK has translated PFS, which was translated to a significant OS benefit in the FLORA trial. Median OS was 38.6 months versus 31.2 months. Hazard ratio was 0.79 months. Next slide, please. Early and sustained sorry. So you can see this Kaplan-Meier curve, sorry, the forest plot in which the osimertinib is compared with the EGFR TK, and all the subgroup analysis favor the osimertinib arm, suggesting the benefit of osimertinib. Next slide, please. So this is the uh, this is the Archer trial, which was suggesting the benefit of decometinib over the gefitinib arm. Next slide, please. So osimertinib versus afatinib. Next slide, please. Next slide. Lux lung, yeah. 7 PFS of afatinib. PSF is significantly longer with afatinib versus gefitinib. Afatinib benefit observed for most subgroups except light smokers. Uh, Median PFS was 11 months versus gefitinib, which was 10.9 months. And osimertinib had a median PFS of 18.9 months. There was insufficient events to determine OS of afatinib at the time of analysis, and the hazard ratio was 0.73. Next slide, please. So afatinib compared with the gefitinib, though you can see that the co-primary endpoint OS survival was not seen when both the afatinib was compared with the gefitinib in the Lux 7 trial, and the curves cross each other. Next slide, please. Osimertinib safety profile was comparison with any other TKI, and you can see the usual side effects of the EGFR TKI like paronychia, skin rash, diarrhea, stomatitis. So the dose reduction was quite less in the osimertinib arm as compared to the other trials. Next slide, please. So coming to the FLORA study was also a sequencing study, osimertinib versus comparative arm. Sequencing arm, I first generation TKI was given third generation TKI on progression, and first generation osimertinib had better results compared to the sequencing strategy comparative arm, and the dilemma of sequencing is also resolved by this FLORA study. Next slide, please. So you can see the second line treatment eligible for all is, so we in second line, 10 patients on the first line of second generation TK developed the T790 mutation, and only 73 to 77% of EGFR mutant patients receive second line of therapy, and 30% of patients don't have opportunity to receive any second line therapy. So it is not possible to predict who will develop T790 mutation resistance. Next slide, please. Hence, important to start with drugs with greater benefit compared to other TKI. Next slide, please. So use of osimertinib as second line therapy in FLORA was consistent with expected rate in clinical practice. Patient disposition in comparative arm, second line therapy in comparative arm. In the 30% of patients in comparative arm could not receive the second line therapy, consistent with attrition rates seen in real world studies and other clinical trials. Uh, Next slide, please. Coming to the FLORA-2 trial of the phase 2 trial of first-line osimertinib plus chemotherapy, platinum-based chemotherapy in EGFR-mutated non-small cell lung cancer. Next slide, please. So this is the trial in which patients with Treatment-naive patients with advanced non-squamous, advanced non-small cell lung cancer with EGFR exon 19 deletion or L858R mutation, WHO PS0 or 1 stable CNS mets were permitted, and osimertinib was compared with the osimertinib plus chemotherapy arm, and chemotherapy which was given was platinum chemotherapy. Next slide. Yeah. These were all the subgroups which were classified as the baseline subgroup. And you can see the sex, race, WHO performance status, histology characteristics, EGFR mutation, and the disease entry, CNS mets, extrathoracic mets, liver mets, bone and locomotor system mets, medium baseline tumor size. Next slide, please. So you can see the PFS according to investigator assessed analysis. The hazard ratio was 0.62 in the osimertinib with chemotherapy arm, suggesting the benefit of osimertinib with chemotherapy, and the PFS, according to blinded independent central review, the also favored the osimertinib with chemotherapy. Hazard ratio was 0.62, and the PFS for survival among patients with CNS mets at baseline hazard ratio was 0.47, suggesting osimertinib plus chemotherapy winner over the osimertinib arm, which is 24.9 versus 13.8 months. And without CNS mets at baseline, osimertinib plus chemotherapy was 27.6 versus 21 months. The hazard ratio was 0.7. Next slide, please. Coming to the FLORA-2 conclusions, primary results of the phase 3 FLORA-2 trial show that combined treatment with osimertinib plus chemotherapy significantly improved PFS versus osimertinib alone in treatment-naive patients with EGFR mutated advanced non-small cell lung cancer. Investigator assessed median PFS 25.5 months versus 16.7 months. PFS benefit was observed across all predefined subgroups. Mature PFS2 and OS data are awaited, and additional efficacy is analysis are underway. Safety profile of each regimen was as expected and manageable with the standard of supportive care. Investigators concluded that osimertinib plus platinum pembrolizumab is a new treatment option for patients with newly diagnosed EGFR mutated advanced NSCLC. Next slide, please. So coming to the NCCN guidelines for therapy for EGFR mutated non-small cell lung cancer, you can see that if the EGFR exon 19 or exon 21 deletion is L858R mutation is present and EGFR is discovered prior to the first line therapy, we can start with the upfront osimertinib, or as discussed in the FLORA-2 trial, like osimertinib can be combined with the chemotherapy, with the pemetrexed or the cisplatin or carboplatin, and this on progression, then we shift to subsequent therapy. And the EGFR mutation discovered during first line systemic therapy, we complete the planned systemic therapy, including maintenance therapy or interrupt, followed by osimertinib. So osimertinib has been given a preferred recommendation in first line treatment. Next slide. Conclusion: for the first time in the evaluation of EGFR TKIs, osimertinib treated PFS to a significant OS benefit. Osimertinib has a median PFS of 18.9 months and a median OS of 8.6 months, which is significantly higher than the first and second generation EGFR TKI. Osimertinib has shown efficacy in patients with CNS mets. Fewer CNS progression events were observed with osimertinib when compared to the standard of care. Fewer and less serious adverse events give osimertinib a better safety profile than the other EGFR TKI. Osimertinib is the new standard of care for first-line therapy in patients with EGFR mutated advanced non-small cell lung cancer. Next slide, please. I think we are done with this.
Thank you so much, sir, for your talk. So for our next talk, I would like to invite Dr. Amit Badola. He's associate consultant from Max Super Specialty Hospital, Shalimar Bagh. So the stage is all yours.
Thank you. Let me share my slide. My slides are visible.
Yeah, sir. Just make it full screen.
Yep. Very good evening, everyone. My topic is real-world evidence of osimertinib as a standard of care in management of EGFR mutated lung cancer. We know that with FLORA, osimertinib is a standard of care now, because it has shown progression-free survival as well as overall survival. It increased uh, progression-free survival from 10 months to 18.9 months, and it has shown the overall survival benefit as well, uh, almost 38.6 months versus 31.8% when we compared it with first generation TKI. We know that osimertinib, if we compare with the first generation TKI, it showed, it beats first generation TKI in every terms. So this was the FLORA trial, which was a landmark trial, published first data in 2019, and then the survival data of this trial was published few years back. And we know that they included advanced non-small cell lung cancer patients who were harboring exon 19 and exon 21 mutation. They were randomized into osimertinib versus standard of first generation TKI. Overall survival was the secondary endpoint in this trial. So this was a baseline characteristics of the population, which was balanced in both arms, and there was almost 19% patient who were having a CNS disease at baseline. As I talked earlier, it showed progression-free survival, and it was irrespective of all groups. Osimertinib showed progression-free survival benefit. If we talk about the overall survival at 3 years, it was 54% versus 44%. In the talk of months, it was 38 versus 31.8 months. So we know that we have already incorporated this in our clinical practice. FLORA showed significant progression-free survival as well as overall survival benefit, but this was all trial. So today I'll going to show some real-world data of osimertinib, and we all like with previous speaker told, osimertinib is the first line in all setting now. So now we'll talk about the real world evidence of osimertinib, and we have few studies here. We'll start with the flower study, and it was similar to Flora trial, but basically it want to show us the real world data of the osimertinib. So this was the key features in this trial, the baseline, median age was 68. Baseline brain metastasis was seen in almost 30% of the patients. Majority of them were stage 4. And the inclusion and exclusion criteria is almost same, which was in the Flora trial. And this was the endpoint. So they took time to treatment discontinuation as a measure, which was measured from the osimertinib start to discontinuation because of any cause, either death or progression. So the primary endpoint in Flora, the primary endpoint was progression-free survival, but in this Flower trial, the primary endpoint was median time to discontinue. It can be because of any cause, because of side effect, because of disease progression, because of death. And the secondary endpoint remain overall survival, progression-free survival, response rate, and disease control rate. So if we talk about the effectiveness, as we know that osimertinib can cross the blood-brain barrier. So patient with a poor performance status, comorbidity, the patient who were rare EGFR mutation, they all were included in this trial, which were not included in Flora trial. An outcome was similar to the published data. So that's what it was adding more consistency to the osimertinib efficacy. There was no difference in PFS, time to treatment discontinuation, or OS uh, in elderly population. So this was the effectiveness. If we see the time to treatment discontinuation, it was 25, around 25 months. If we compare it with patient between who was symptomatic or non-symptomatic, to the patient who were non-symptomatic, it was not reached. the median was not reached in those population. But if we'll talk about those population who were symptomatic at the time of diagnosis, the time to discontinuation was around 18 months. So if we'll see the time to discontinuation in the patient who are having more than three bony mets, it was around 21 months. Not bony mets, any mets, it was around 21 months. It is same. So if we'll see which patient did poor on osimertinib, we all know that a patient who was having brain metastasis symptoms at the time of diagnosis and that metastatic site more than three, these all are associated with the poor outcomes with osimertinib. Anyway, these all are anyways are poor prognostic markers. It's showing the same thing. So if we talk about the response rate, it was around 73%. There was no CR, but the partial response was around 73%. If we'll talk about this progression-free survival in patients who were having brain metastasis or the patient who were not having brain metastasis, the patient who were having brain metastasis is around 13 months. And the patient who were having no symptoms at at presentation, the median was not reached. Why? The patient who was symptomatic, the progression-free survival was 15 months. Same. The real-world diagnostic therapeutic pathway, basically this slide want to tell us that after progression, how many patients, like we know that in our clinical practice, if the patient has progressed on first generation or second or third generation TKI, we should do rebiopsy or at least liquid biopsy to see the mechanism of resistance. So in this trial, they have 44 patients. They underwent on progression. They underwent for the biopsy. 14 cases they underwent the tissue biopsies. In 6 cases they underwent the liquid biopsies. And the mechanism of resistance, we see it was MET amplification, MET amplification, or EGFR amplification, HER2 amplification. In this, most common side effects like diarrhea, ILD, rashes, paranoia, VT. VT is actually the most common side effect, which was having grade 3 toxicity, 7.9%. But it was not associated with any age, performance status, comorbidity, or tumor load. Another real world study was OCFACT. The purpose of this investigation to investigate the differences in the efficacy with the patient background and the safety of the first line of osimertinib treatment in the real world. So the question which this study asked was, sorry, the safety of safety of osimertinib in the first line. So if you'll see, the inclusion criteria is more or less same, which was in FLORA trial, advanced EGFR mutated non-small cell lung cancer, and they exclude those patients who were receiving osimertinib as a second line or post-operative adjuvant chemotherapy or patient currently using any anti-cancer agents or undergoing thoracic radiotherapy. They all patients were excluded in this study. If we'll see the baseline characteristic in this trial, the majority, almost 37% patient were more than 75 years of age. Majority of the patients were female, around 65% patient. If we'll see the PD-L1 status, around 11 or 12% patient were having PD-L1 more than 50. Because why I'm talking about the PD-L1 status, because in this trial later on, we'll see that the patient who were having more PD-L1 were having poor progression-free survival. So the primary endpoint was progression-free survival, just similar to the FLORA trial. The secondary was OS, but the another important was time to treatment failure. The third was response rate, safety, and the post-treatment. Objective response rate and the disease control rate were the other secondary endpoints. We will see the primary endpoints. The PFS was almost same Like in Flora, it was 18 months. In this trial, it was around 25 months, 20.5 months. But the parameters which was associated with poor performance status was male gender, patient who were having malignant diffusion, the patient who were having liver metastasis, or advanced unresectable cases. With respect to PD-L1 expression, as I was talking earlier, the PD-L1 expression more than 50 was associated with less smaller progression-free survival, like 11 months compared to a PD-L1 negative patient who were having the PFS didn't reach in those population. It's the same. Time to discontinuation, that is important. The reason for the treatment discontinuation. So in around 44% patient, the reason of treatment discontinuation was disease progression, while pneumonitis in this study was the second most common cause of treatment discontinuation. But in flower study, which we talked about earlier, the most common grade 3 toxicity was DVT. But here, the most common cause of treatment discontinuation was pneumonitis, which was all grade is around 13%. So conclusion of this study that we all know that in real world also osimertinib was showing progression-free survival benefit. Discontinuation rate was around 18%, and we have to take care of pneumonitis during the patient follow-up as well. Another study of osimertinib in the real world, this is a kind of a observational prospective study conducted in the US to report the demographic and the clinical characteristic of real world time to treatment discontinuation and time to next treatment or death in patient with advanced EGFR mutation non-small cell lung cancer who received the first line osimertinib in US. The study design is quite similar to a Flora trial only, and the first interim analysis was published in 2020, and the final plan was June 2023. So this was a study design. The first patient identification started in 2018, and the first interim analysis came out in 2020, and then later on the final analysis came in June 2023. So if we'll see, this is the baseline characteristic of the trial. They included almost 548 patients. If we'll see, 35% patients were more than 75 years of age. Uh, Majority was white, but there was like fair number of patients who were Asian, African, or other race. They took majority of the patient from the community rather than in academic center, as it was a real world study. If we see, majority of the patient were stage 4 disease, having metastatic site, more than 4 was only in 12%. Brain metastasis was allowed in this study, and the 33% patients were having brain metastasis at present. This is the EGFR mutation distribution. Most common was exon 19 deletion, followed by L858R. So at interim analysis, which was in 2020, almost 58% patient remained on therapy. 18% received second line treatment at that time, and 18.4% died on the first line while on the first line. 4% patient discontinued the treatment. So if we'll see the time to next treatment or death, it was around 17, median was 17.9 months, 18 months, and 18.4% patient died and 18.8% switched to next therapy. And the factor which was associated with this poor time to next treatment or death was patient who were smoker, comorbidity index more than 3, EGFR mutation type, if it is a rare type, number of metastases is more than 4, they all dead poor. Time to treatment discontinuation, median was around 17 months, and like we discussed earlier, 18.4 patient died, and the similar number of patients switched to the second line of treatment. The take-home message was real. This also support the osimertinib in all setting of the non-small cell lung cancer who are having EGFR mutation. This time to treatment discontinuation and death support the effectiveness of osimertinib in the real world population. We need longer term outcome will be evaluated in the final analysis, but it was also published in 2023, which was also in favor of osimertinib. Thank you.
Thank you so much, sir, for your talk.
Thank you.
So, for our next talk, I would like to invite Dr. Tanushri Mishra. She is a radiation oncologist from Cuttack. The stage is all yours, ma'am.
Good evening, everyone. Sharing my screen. Oh, you are sharing? Okay.
Ma'am, you want me to share?
Yeah, because as you are sharing, I'm not allowed to share. If you share, it's okay. You share.
Okay, I will share. I hope, ma'am, the screen is visible.
Yeah.
Yeah.
Okay. So let me first thank the organizers for including me in this event. So good evening all. So we will be discussing about optimizing treatments in advanced EGFR mutant lung cancers. Next. So as we know, non-small cell lung cancers, mostly they constitutes of adeno cancers. So adeno, as we know, EGFR is the most common mutation we come across the world. And in Indian scenario also, around 30% patients in your clinical practice, you must be seeing that they are EGFR mutants. So EGFR mutation subgroup is a very they constitute a vast majority of patients that come to us, and if they are not being evaluated or treated initially in a very meticulous way, they end very badly. So this population of patients are our target population in this discussion. So we'll be discussing a little bit about EGFR mutations and all that. So EGFR mutations mostly it occurs because of deletion in exon 19, or either in the exon 12 defect, or in exon 18, 21. So 21 and 19 are the most common two sites where AGFR mutations occur. And in our scenario, more than around 30%. Here it shows around 20 to 23%. Roughly, we can say 30% patients are EGFR positive patients. Next. And this EGFR mutation is being targeted by these tyrosine kinase inhibitors, because when there occurs mutation in the EGFR gene, that occurs excessive adenosine kinase activity, and there is proliferation of the tumor cells very fast. So we need to block that proliferation, and we need to restrict that. So for that, what we use a tyrosine kinase inhibitor, and tyrosine kinase inhibitors are now more and more newer generations are coming. We'll be discussing about basic things: first generation, second generation, and now the third generation TKI. So first generation, what they do, they reversibly bind the wild types and mutant EGFR. So what occurs, as it reversibly binds, when the effects goes up, again the cell proliferates. So uh, they were of use when there was nothing to use. So they were the standard of care. We can say that prolongs many life in our clinical practice. We must have seen that many patients, those who were hopeless, they got some few months of life with this allottinib, gefitinib when they came first into market. Then coming to the second generation also they bind actually covalent bonding. They are not reversible, but irreversible in a covalent type of bond, that is a very loose bond, and that it has some broader activity as compared to the first generation TKIs. Now the third generation, what we will be discussing today about this osimertinib. Osimertinib is a EGFR mutant specific inhibitor, and it irreversibly covalently binds the mutant EGFR specificity for the EGFR T790M mutant variety and EGFR wild type sparing type. So this what is this T790M mutant? That because sometimes what happens after TK is being used for a longer time, patients do not show any response. There occurs a mutation in the T790 portion of that particular exon where it becomes resistant to the therapy. So these osimertinib third generation TKIs, they are very specific activity against this EGFR T790M mutant variety. And next. So it is now it is the new standard of care, first line in advanced and metastatic non-small cell lung cancer. But how it came to practice that it is the standard of care? For that, we have to go long back. As our previous speakers, they elaborately they described the FLORA trial. But again, I will tell some catchy points of FLORA trials, why we believe that osimertinib should be the new standard of care. So the FLORA trial is a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as first-line treatment in patients with locally advanced or metastatic EGFR mutant non-small cell lung cancer. Next. It is actually structurally different from first two generations TKIs because it binds irreversibly to that receptor particularly, and the first generation, that is gefitinib kind of things, erlotinib, gefitinib, they sensitizes the EGFR mutations reversibly and reversibly bind to the EGFR ATP binding site. So on use for a longer time, they acquire resistance in the form of T790M mutation or any other mutation that causes resistance to the therapy, and patient again progress to further progression of the disease occurs. So now coming to the third generation, this osimertinib, this is the EGFR sensitizing mutation T790 mutant resistant mutations, and it binds irreversibly, and ATP binding sites of EGFR, that is the cysteine amino acid cysteine 797 position, and it is a monoanilino-pyrimidine derivative. So it is structurally completely different from first two generations TKIs. Next. Because of this special molecular structure of this molecule and this chemical composition and the way its characteristics are made like that it crosses the blood-brain barrier. So the first and foremost advantage of this TKI we are having, that it crosses blood-brain barrier where the first and second generation they cannot. So it is the first advantage we have in our hand. Second, it is T790M mutation resistant, and third is it binds irreversibly with the bind. So three plus points we are having in basket of osimertinib. Now it is it is as I just told that this is the pictorial presentation. First generation, second generation, and third generation we discussed. Now this is the particular action of osimertinib, that EGFR mutant exon 19 deletion and L858 resistant cases, it binds to the receptor the way you can see. Not so snugly, but it snugly fits. In the EGFR T790 mutation, it snugly fits to the receptor, but in wild type EGFR, it doesn't work so efficaciously. So it inhibits the EGFR mutation exon 19 deletion, inhibition of T790M mutation, and it has lower activity against wild type EGFR. And it crosses and crosses the intact blood-brain barrier as seen in human and preclinical models, in animal models and in human also. So as we know this non-small cell lung cancers, And in our setting, in our country, with limited resources, these cases are not being evaluated properly at the time of diagnosis. So we don't know what the course the patient is going to have. But very often we can see in our clinics that patient develops brain mets very early. Very in around 25% cases, you can see the patient will develop brain met in the latter stages of the disease. So it is the first important, very important advantage that this molecule is having, that it crosses the intact blood-brain barrier. Next. Next, please. Yeah. So the most discussed flora study by my previous speakers, this flora design is also being discussed previously, but I will tell again that it is the landmark trial in history of non-small cell lung cancer in targeted therapy. Flora is the landmark study. No one can deny that. So in this study, the patients were locally advanced or metastatic non-small cell lung cancers were included. And the inclusion criteria were, as we can see in all study, age more than 18 years, WHO performance status 0 to 1. But in the previous talk, we were seeing that in some real world studies, they were also included performance status 2, 2. But here only 1 and 0 and 1. Exon 19 deletion, then L80, L858 are no prior systemic anti-cancer. No prior systemic anti-cancer patients were included in this trial. As first line, they will be treated with osimertinib. And stable CNS metastatic cases were also included in this study. So 1:1 randomization was done, and osimertinib dose was 80 milligram orally, and EGFR other TKI standard of care gefitinib, erlotinib, they were given as per their scheduled dose. So they were every 6 weekly they were monitored with serial CT scans, and RECIST criteria was used to assess the progression or stable disease or any change in disease status. But here one thing was done, that crossover was allowed only in the standard of care TKI group, where those patients with progression disease, they were changed to osimertinib or any other treatment, but they were not, if they were changed to osimertinib, they were not included again in the study. Okay, so this will not create any bias. Next, stratification factors were exon 19 deletions and L858 are resistant, and Asian and non-Asian race were also been stratified differently. Primary endpoint was PFS. Here, PFS was the primary endpoint. And next, it was assessed by RECIST 1.1. And secondary endpoint was objective response rate, duration of response, disease control rate, depth of response, and overall survival, patient reported outcome, and safety. One thing is important here, depth of response. How we can measure that? That is measured by with what rate the size of the tumor is increasing compared to the baseline T till the present stage. So depth of progression is a very important prognostic thing in seeing any kind of drug effect in a trial. And duration of response is also very important. And objective response rate, that's the first thing we have to see in secondary endpoints. Then primary was PFS in this study. Next. So it demonstrated a significant improvement in PFS. That is, the primary endpoint was reached, and the median PFS was 18.9 versus 10.2 months in the standard care TKI, first generation TKI group, where previously patient could sustain a 10 months progression free. Now it has increased almost double, 18.9 months. Okay. So in a stage 4 lung cancer, if a oral tablet can give us a double progression-free survival, then what else? So PFS is a direct measure of drug benefit here. So, and Flora was powered with PFS. So it was a very powerful study to show that how PFS can translate to OS. That later we will discuss. Next. Next, please. Yeah. So efficacy of osimertinib across the all clinical subgroups, that is the sex of the patient, then age at the time of screening, race, Asian, non-Asian, as we discussed, and smoking history present or not, then CNS metastasis, if present or not, then symptomatic or not, that were also taken subgroup analysis, and WHO performance status, EGFR mutation at randomization, EGFR mutation by circulating tumor DNA, then centrally confirmed EGFR mutations. These were the stratification subgroups where all over the subgroups the PFS was studied in the plotted in the forest plot, and we can see in all the characteristic it favors the osimertinib arm. Maybe the difference or the magnitude is little bit different in all arms, but they all favors the osimertinib arm as compared to the EGFR TKI comparator group. Next. Here the overall survival was done, and we can see that median overall survival was 38.6 months in osimertinib arm and 31.8 months in the competitor EGFR TKI. Here the p-value is not significant, and also our aim of our study, this FLORA study, was not to see the OS, it was to see the PFS. Until the it is up to more than 3 years it was studied and patients were still alive. So what we draw from this study, that median OS was more than 3 years. Osimertinib patients were more likely to live at 2 years and 3 years landmark. For a stage 4 lung cancer, if we live with a tablet only for more than 2 to 3 years, then what else? Then first time EGFR TKI has translated PFS with significant OS benefit. Maybe in few weeks it could have shown any benefit, but here we can see more than 3 years the OS is having as compared to the other TKIs used in the other arm. So if this is the condition where we use this drug in this metastatic advanced cases, because all studies are done always in the advanced stages first, then it comes to early stage. So I think in early stage also it would reflect the same result. Next. And 28% of patients are still receiving osimertinib at 3 years. Means the safety profile of this drug is so good that even after continuation 3 years of use, patients still can receive this drug without any serious adverse effect. 28% patient means more than 1/4 of the patients, they are still continuing with the drug. And 3 times more than participants in the comparative arm. 22% versus 5% of all patients still on the treatment at the cutoff data. So this is the data where we can see till after 36 months also 28% patients were still receiving osimertinib, because our endpoint was means if there will be disease progression, we'll stop the drug. Here disease progression has not occurred till 3 years, and patient is still surviving and taking the drug. Next. Then time to first subsequent treatment. Subsequent treatment will occur when there is progression and we are going to stop the drug. We will have some other drug or other elements of treatment in our hand. So that point in the time to first subsequent therapy or death, event is death. If death will occur, there will be no treatment. So as is respect to this, in osimertinib, the median month was 25.5 months, whereas in the comparator EGFR TKI, it was 13.7 months. So almost double. Here we can see that duration is almost double, means the event like death or any progression has occurred almost double time after use of normal standard of care TKI than osimertinib. Next. Efficacy of osimertinib across the clinical subgroups. As we have seen in the PFS terms in the previous forest plot, here in the same slide, OS and PFS has been shown, and all the points, all the subgroups we can see the PFS favored the osimertinib as well as in the OS arm also. Though in the OS, the p-value was not significant, we cannot establish this, but still in this forest plot, we can see all the parameters in all subgroups that favors the osimertinib, except we can see in the race, if we see Asian, non-Asian, and in Asian race, both almost similar. There is no favor for the osimertinib. And another one is also EGFR mutation and randomization, that is exon 19 deletion. These subgroup also, they have similar OS as compared to the competitor TKI. Or else all other subgroups, they have a much more favorable result in terms of OS as compared to the comparator TKI. Next. So PFS benefit was clearly maintained consistently across all subgroups, demonstrating its superior benefit across all population, including by race and across the different mutation types, which is important as well as we discuss in the OS subgroups. So both are very important. And all OS subgroups showed positive benefit in favor of osimertinib, although the magnitude of benefit varies, as we discussed just now. And this is consistent with PFS data in all subgroups that favored osimertinib. Next. Now, why do you think it is important the patients receive osimertinib in the first line? This is the point. Why do you think so? Because it is much costlier than the first and second generation. If progression occur, we can switch to second line. Then why should we use it in first line? We'll discuss that next. So it has been seen that approximately 30% of all patients are eligible for osimertinib as second-line treatment for T790M mutation positive non-small cell lung cancers following progression on a first or second generation EGFR TKI. That is, out of 10 EGFR mutant patients who start on first generation EGFR TKI, out of them 30% they are eligible for osimertinib as second line. Only 30%. Okay, only 30%. That we will see. Out of 10, only 3 were eligible to receive osimertinib as second line. And we have already seen the response rate of osimertinib in terms of PFS and OS. So next, approximately 50% patients who are alive and who are able to get an accurate test of T790M mutation positive, only 50%. This is very important. Out of 100, we can get only accurate test result in 50%. And that cannot predict which patients will develop T790M mutation resistance. That is also very important vital point, because we cannot predict that by seeing the genetic profile of the patient. And some patients do not even get that far. Only 70 to 80%, 70 and 80% patients can receive an accurate T790 test result, because either the tissue biopsy sample was not eligible for the testing, or insufficient tissue biopsy, that is invalid test results, and false negative on plasma test, liquid biopsy. These are these tests are actually very sophisticated. We may not always get a good result on plasma test, so false negative test also result also can come from that. And only 75% around patients of EGFR mutant patients receive any second line therapy. They either die during the first line therapy, or they go upon palliative care or any clinical trial chemotherapy like that, because their general condition doesn't allow us that we can give osimertinib to a second line. So we are getting only 30% patient. Out of 10, only 3 are becoming eligible to receive second line therapy. Next. This is a very good pictorial presentation of what we have discussed just now, that EGFR mutation positive non-small cell lung cancer, only about 1/3 of the standard of care TKI patients will receive osimertinib in future. Out of 10 patients, if hundreds are there, around 75% patients, they will receive second line therapy, and 30% again, they drop at that level only. They die during the first line therapy only, or they receive only palliative care. No T719 test was done on those people, those who died or who went to supportive care, so palliative care. Next, Rest 75% from them, around 60 to 75%, they receive a valid T790M test result, because others are not eligible for tissue biopsy, as we discussed, because when we get a progression, we do a rebiopsy, and sometimes it is not possible. Many factors are there: patient general condition, financial condition, then lab facility, and pursuance of the patient's relatives and the support staffs, that the patient again should be rebiopsied, and rebiopsy and other genetic tests should be performed. So this is not always practically possible in our setup. So insufficient tissue from the biopsy or an invalid test results, or to get a false result on plasma, as we discussed just in the last slide. So out of these patients, only 50%, those who with a valid test report, from there we get 50% positive, rest 50% negative. So out of 60, 30, 30. So at last we get only 3% out of these 10 patients, that only 30% patients, they become eligible to get second line osimertinib on their progression on first line standard of care TKI. Next. So only around 60 to 79% of patients can receive an accurate T790M test result, what we showed in the last slide. That is not just we said, because it has been seen in several studies, that the summary of the rebiopsy results in different clinical trials, we can see the gist of this slide is only 30% patients we can get. 50% of the test done, we get 50% positive, and total from the total population we can get only 30% having a test positive report with us to use osimertinib as second line. Plasma testing may yield false negative result. It has been seen in many studies, so we'll not opt for that. We'll do a rebiopsy and tissue biopsy only. Okay, next. Then crossover rates and subsequent second-line therapies for the FLORA experimental arm. In the FLORA, we can see that this osimertinib arm, out of 100, 78% discontinued treatment and 22% continued on treatment. So after that, what happened to this 78%? Out of this 78%, 30% received no subsequent treatment. Either these patients, these patients in the experimental arm also could not receive any second line therapy. Either they left the trial, they did not follow up, they showed poor response, or they died, or whatever, they did not receive any second line therapy. And this 48% received second line therapy. They, in terms of other than osimertinib or any cytotoxic chemotherapy or like that, 48%. Remember this. In the second, we will discuss the comparator TKI. Next. In the comparator EGFR TKIR, here only 5% are on treatment at the time of this study, this discussion. Then 95% discontinued. Here, there we saw 78% discontinued. Here 95% discontinued treatment. Out of this 95%, 30% patients, they could not receive second line therapy because of the similar reasons, because of their personal problems, clinician problem, whatever may be their economic status or whatever, they did not receive any second line therapy. They succumbed, or they received supportive care or something. Then out of these 65% patient, they go for second line therapy. Okay, this second line therapy is either in the form of osimertinib or any other form, or maybe any other TKI. So out of these 65%, around 47% patients, they receive osimertinib. So this represents 31% of all patients. They were in the 277 patients in the other arm. Out of them, 85 patients in the second line, they received osimertinib. Next. Yeah, that we discussed. Next. Yes. In the real world study of patients with EGFR mutation non-small cell lung cancer, the risk of not receiving second line therapy is very high, because we can see only very few percentage of patients, they go for second line therapy. Out of them, very few qualified for osimertinib therapy. So overall second line therapy, it was a very raw data because it's a retrospective study of 140 patients with EGFR mutation and non-small cell lung cancer in Germany to identify the treatment patterns. Here what happened, out of 130 patients, 140 patients, 130 patients were treated with first line EGFR TKI, 10 patients received first line chemotherapy. Then 112 patients were candidates for second line therapy. Out of these 130 patients, 112 patients were qualified for second line therapy. And out of them, only 34, that is 30% of these patients did not receive second line therapy. And the reason is maybe patient's refusal. Many causes are there. Poor performance status or very fast progression to death, very poor general conditions. So any one could be the cause. And 104 patients in this study were treated after accessibility to third generation TKI. Across all lines of therapy, only 29% were treated with third generation TKI after accessibility. So as we are discussing in the FLORA trial, 30% patient could receive second line osimertinib from the first arm. Then here we can see almost similar in the real world study, around 29% could do that. Next. So this is the real world data across multiple countries that confirms that in clinical practice, 1/3 or fewer patients receive second line osimertinib. Percent second line osimertinib in a real world study in United States, then in European countries, in Asian subcontinents. Here we can see several studies, landmark studies have been depicted here, not all. We can see that the percentage vary from 9% to 36%, taking into account the average being 30%. So these patients only qualify for second line osimertinib in clinical practice. Next. Then head-to-head clinical trials of EGFR TKIs are consistent with real-world data. Not all patients can receive second-line osimertinib. This is very important. As Archer study was described by my previous speaker, they are in FLORA also. Second line, only 31% in FLORA and 11% in Archer. They could receive second-line osimertinib in their treatment course. Next. Then coming to treatment sequencing in advanced EGFR mutant non-small cell lung cancer, survival with first line versus second line osimertinib, because our all motto is survival. So first line osimertinib we give for when we use it first line around 19 months average, there may occur progression or any adverse effect or anything that we have to discontinue. Then we can use chemotherapy all patients. Okay. Next, second generation, no, standard of care TKI that is available, the first generation. There, what happens? The standard of care TKIs, they can sustain only 10 months. After that, either they have to switch for osimertinib or chemotherapy or supportive care, depending on the patient's condition. As we discussed repeatedly in previous slides, that only 1/3 patients could receive second line osimertinib. Next. So the key messages in the FLORA was that osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. And the FLORA trial was the first to demonstrate how an EGFR TKI has translated PFS into OS benefit. Osimertinib improves OS versus first generation EGFR TKIs in untreated EGFR mutant plus and non-small cell lung cancers and T790M non-small cell lung cancer that had progressed on first line EGFR TKIs. And osimertinib is the only EGFR TKI to report statistically significant intracranial efficacy. Because of that, only this drug could stick. Then osimertinib is well tolerated and its recommended dose is only 80 milligram orally. It is very convenient for the patient to take. Then adverse effect leading to dose reduction are frequent in the second generation EGFR TKIs, afatinib and acatinib, here less. Sequencing cannot be considered the best strategy in almost 70% patients are not eligible to receive osimertinib as second line because only 30% they qualify the criteria to use osimertinib as second line. So these data confirm osimertinib as the first line standard of care in metastatic EGFR mutant non-small cell lung cancer. Next. And we cannot do anything with the studies only. We have to have an category 1 recommendation. So as we all owe to NCCN guidelines, the category 1 recommendation first line therapy for EGFR exon 19 deletion or exon 21 L858R mutations, EGFR mutant discovered prior to first line systemic therapy is osimertinib, is the preferred drug. Other recommendations are there, osimertinib with pemetrexed or erlotinib, afatinib, everything is there, but first is preferred is osimertinib. Next. Thank you. I think we are done with the slides.
Thank you so much, ma'am, for the talk. So for our last talk, I would like to invite Dr. Ashish Upadhyay. He's a medical oncologist and hemato-oncologist from Kolkata. So the stage is all yours.
Good evening, everyone. First of all, I would like to thank AstraZeneca for inviting me. I would share my slides first. Are my slides visible?
Yes, sir, please.
Are they moving?
Yeah.
So thank you very much. So I'll be talking about reimagining CNS mutation in metastatic EGFR positive advanced lung cancer and how treatments compare. To start with, first the incidence we all know, majority of the lung cancer, they are non-small cell lung cancer, around 85% of them. And if you see the molecular classification, then the most common targetable mutation is EGFR, accounting for around 17% of the patients. The second common mutation is G7, G12C mutation. Then we have BRAF, MET, RET, ELK, EGFR mutations. Just if sorry. So if you talk about the incidence of EGFR mutation across the world, then we see it ranges of around 15% from Europe to around 40% in Asia. In America, it ranges from around 20 to 25%. Africa, again around 25%. South Africa 20%, and Asia you can see the maximum percent, that is 36 to 40% of the patients. So there is marked geographical variation in EGFR mutation prevalence ranging from 15% in Europe to 40% in Asia. We also know that they have a high predilection for CNS metastasis, especially talking about the EGFR mutation. There was a study by Hubbs et al. In which he took factors associated with the development of brain metastasis. He took around 975 early stage lung cancer patients. At a final follow-up, it was found that 44% of the patient in EGFR positive had brain mets compared with 22% of the patient with those who got only without EGFR. And if you talk about the leptomeningeal seeding, that also is more with EGFR positive, that is around 9% versus 1%. So approximately 10 to 20% of the non-small cell lung cancer, they have brain metastasis at the time of diagnosis, and another 40% will develop during the course of the disease. So this was another study by Peters et al., which assessed the quality of life as compared to the different metastatic sites. It was seen that those patients who had brain metastasis, they had maximum deterioration in the quality of life. You can see clearly the rightmost curve. And those, especially those patients with single brain metastasis, they experienced greatest decline in the quality of life compared with other sites. So we know brain metastasis has been a problem with EGFR positive lung cancer patients. Now, what is the relation between EGFR mutations, TKI, and brain metastasis in non-small cell lung cancer? So what we already know, What we already know is brain is a sanctuary site that is important for metastatic tumor. It is usually protected by blood-brain barrier. Up to 40% of the patients which EGFR will eventually develop brain metastasis. And EGFR TKI are also substrate for human blood-brain barrier efflux transporters to varying degrees, and this influences the distribution of compound in the brain at equilibrium. Hence, it is imperative that EGFR TKI must have a good brain exposure if they are to achieve intracranial efficacy. So now we'll talk about few of the pharmacokinetic studies to see the osimertinib penetrance in blood in the brain as compared to the first generation and second generation TKI. It was again a study by McClock et al. In which the brain penetration of the different generation TKI was seen. You can see choline 11 PET scan was used for that. And the first picture is with osimertinib. You can see the clear uptake with osimertinib is more as compared to the first and second generation TKI, that is gefitinib, erlotinib, olvertinib, ruxolitinib. They are again third generation investigational TKI. The same result, we can clearly see the brain Cmax concentration was more with osimertinib as compared to gefitinib, and the brain to plasma Cmax ratio was more with osimertinib as compared to gefitinib and other investigational third generation TKI. The graph also says the same. You can see the clear uptick with osimertinib. So this study shows that osimertinib is the highest brain penetration across all the EGFR TKIs. Now, another study by Ballard et al., in which an intracarotid tumor injection in a mouse was done so that the mouse can develop a tumor. And after that, osimertinib was given, another drug, CO1686, was given. We can see with osimertinib, the PC tumor growth inhibition is more as compared to the vehicle. So we can clearly see that the penetrance of osimertinib is there and it is effective as well for brain mets. Now, this was again a study which was done by Varon et al., in which healthy patients were taken, around 8 subjects were taken, again to see if osimertinib has been homogeneously distributed along different regions of blood or not. So we can see across all the subjects, all the 8 subjects which were healthy subjects, that the distribution of osimertinib was uniform. Then another study in which 2 patients were taken and to see the effect and the efficacy of osimertinib in brain mets, especially EGFR positive patients. So the first patient we can see on the left side, day 1 baseline PET scan was done. After that, the patient was started on osimertinib on day 2, that is 6 hours post single dose osimertinib of 80 milligram. We can see the increase in uptake of osimertinib in the brain. And on day 22, we can even see the more increase in uptake and regression of the lesion. Similar finding can be seen on the right side also for the second patients. On day 22, you can see good uptake of osimertinib in the patient. So what we already know, so now we know that osimertinib binds irreversibly to clinically relevant mutant. That is exon 19, exon 20 mutations, and also T790 mutation, which is present in exon 20. It prolongs PFS and OS as compared to first generation TKI. It exhibit anti-tumor effects in patients with non-small cell lung cancer exhibiting various EGFR mutation. It has high blood-brain barrier. It has high blood-brain barrier penetration and brain exposure related to other EGFR TKI. And this is basically active against CNS metastasis. It inhibits growth of CNS metastasis also in EGFR positive patients. So how does the efficacy of osimertinib how is the efficacy of osimertinib as compared to the first generation TKI? We know the evidence flora had been discussed in detail by Dr. Tanishri. So we all know at eligibility, there were around 994 patients, which the total 994 patients were screened for eligibility, and out of which 556 patients were eligible. It was a randomized double-blind study in which osimertinib 80 milligram per day was compared with the first generation TKI, either gefitinib 250 milligram or erlotinib 150 milligram. Primary endpoint was in June 2017, and the final analysis was in June 2019. The majority of the patient had metastatic disease, around 95%. And 35% of the patient had visceral metastasis, 21% had CNS metastasis. So the efficacy we can see, the median PFS with osimertinib is 19 months as compared to 10 months with first generation TKI. Median OS also is more 38.6 compared to 31.8%. So we know that PFS is a direct measure of the drug benefit. In patients with brain mets, median PFS was 15.2 versus 19.6 months with osimertinib. And if you talk about the OS, and at 3 years, 44% of the patients were on osimertinib were alive compared to only 44% in first generation TKI. So this, and also have to see if this drug is effective both in patients with brain mets and without brain metastasis. So this also was seen. So in those patients with brain mets, we can see the hazard ratio is 0.47. Median PFS increased from 9.6 months to 15.2 months. And those patients without brain mets also, they also got equally benefited or slightly better because the hazard ratio was 0.46. The median PFS increased from 10.9 months to 19.1 months. And also CNS progression events occurred in only 6% of patients on osimertinib compared with 15% of the patient on first generation TKI. So in FLORA, osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease at entry point. Now we'll talk about the CNS full analysis. This again, there was an abstract presentation in ESMO 2017 in which intracranial PFS was assessed, in which again CNS full analysis subset, we can see total 128 patients are there, in which the median PFS hazard is 0.48. The PFS, CNS PFS with osimertinib is not reached as compared to only 13.9 months with standard of care. So CNS PFS was statistically significant with osimertinib compared to first generation TKI. And you talk about the CNS progression, again, it was better with osimertinib. The in CNS progression was seen in 20% of the osimertinib patient compared to 39% with gefitinib or erlotinib. That is, the CNS progression was half of what we get with first generation TKI. In the FAST also, we could see that CNS metastasis, the response was better with osimertinib. 6% was the event in osimertinib compared to 16% in first generation TKI. If you see the patients who were on TK, then at 1 year we can see 70% versus 47% of the patients were on osimertinib and first generation TK, and at 3 years we can see 28% were on treatment compared to only 9% with first generation TK. So that is a very good result. Now some real world evidence for osimertinib for brain mets patients. So this, again, a rapid intracranial response to osimertinib without radiation in non-small cell lung cancer harboring T790 mutation. This is the first case. A 67-year-old female non-smoker underwent surgery 9 years back, and then again developed multiple lung metastasis 7 years ago, for which the patient biopsy and NGS was done. EGFR L858R positive. The patient was started on gefitinib as first-line therapy. The patient was on gefitinib for 2 years and 11 months, for around 3 years. After 3 lines of chemotherapy, again, erlotinib was administered. And then the patient again failed in 3.5 months. 6th-line chemotherapy was also started. Then the patient developed thoracolumbar bone metastasis. Again, biopsy was done. T790 was positive. The patient was started on 7th-line osimertinib 80 milligram per day. So this is the summary we've already discussed. So this was the patient who received 2 prior EGFR TKIs. After that, multiple course of chemotherapies. Then on 7th line, the patient was started on osimertinib. Before that, NGS was done, which showed T790 positive. So for and 7th line also, you can see good response pre-treatment, and on day 13, the MRI report, you can clearly see it, very good response. The brain mets are regressed significantly, and so has the pulmonary lesion. You see on the left side, on the right middle zone, there is a slight opacity which has gone down in the right side also. Another case, 76-year-old male, a smoker, again surgery 10 years back. Then EGFR analysis was done. Exon 19 was positive. The patient developed multiple bone metastasis. Gefitinib was started on of gefitinib for 4.5 years. Then afatinib for 10 months. And again, re-challenging was done with 4 courses of chemotherapy with bevacizumab. With 4th line chemotherapy, again the patient progressed on CT plus bevaciz. Then again 4th line chemotherapy was started. Again on 4th line also the patient progressed. After that, thoracocentesis was done. Additional T790 mutation was positive. So again, the patient was started on osimertinib, 5th line osimertinib, and we'll see the response in this patient also. You can clearly see pre-treatment on and day 10, there is complete remission of the single metastasis with osimertinib as 5th line therapy. We can see this similar finding with lung nodules also, good response. On the left side, there is pre-treatment CT scan. On the right side, we have CT scan on day 31. There is decrease in pleural effusion and also shrinkage in the lung metastasis size. Another case, a 74-year-old woman without any smoking history, elevated blood CA. The CT scan showed 4 centimeter upper lobe mass with multiple lung nodules. She was diagnosed with stage 4 lung adenocarcinoma, exon 19 mutation positive. She was having more than 20 multiple asymptomatic brain mets with a maximum diameter of 12 millimeter detected via MRI. She again was started on osimertinib. WBRT was deferred because she was asymptomatic for that. And you can see the response, very good response again in this patient as well. The brain mets also responding beautifully. Now, this is a cohort study by Brandon et al., in which it's a retrospective cohort study, which patients selected from institutional database. They were diagnosed case of EGFR advanced non-small cell lung cancer treated with osimertinib, either is first line after first brain radiation or had at least one intact brain mets not previously treated with systemic or local therapy, or had baseline brain MRI before and at least one scan after osimertinib initiation. So we can see in this case also good response with osimertinib. So there were around 36 patients who had a median interval from brain mets diagnosis to first line osimertinib of around 25 days. Total 136 previously untreated brain mets patients were taken. Overall, 77% had complete response, 31 had partial response. There was an objective response of around 100%. 2-year survival was 80%. CNS progression rate at 1, 2, and 3 years were 21%, 32%, and 41%. So lesion level local failure was estimated to be 0.7 and 4.7% at 1 and 2 year post osimertinib. So, and what does the guideline say? We all know the NCCN guideline we all follow. It says the category 1 is osimertinib, but now we have FLORA 2 also. So in young fit patients, basically chemotherapy with osimertinib is the preferred regimen. And in those patients who cannot tolerate chemotherapy and who are who are squamous patients with EGFR positive, osimertinib is the standard of care. Thank you. With this only, I would conclude. And if there is any question, I would be happy to answer.
Thank you so much, sir, for your talk. So I would like to thank every faculty for joining today's webinar.
Okay. So I think that is it.
Yeah,
So if there's no question, we'll just wrap up the meeting.
sure, sir, sure.
Thank you very much.
Thank you, sir. Technical team, can we please close the meeting?
Yes, madam.